Hi, my name is Dr. Walter Tsou. Today I want to talk about the quest for healthcare reform. I'll begin by saying that I have no financial conflict of interest to disclose. I want to acknowledge that there's no domestic issue in this country that is more divided than healthcare. It's arguably the foundation upon which the Tea Party movement was created in America. And you can see by this most recent presidential election, healthcare came up repeatedly in almost every debate. And it's one that actually was a major issue that helped decide the presidential election. At heart, I believe, is a question that we don't ask enough. Is healthcare a public good or is it a market commodity? Do we think that government is the answer or that government is the problem? Do we believe that private insurance cannot be trusted or that private insurance works, quote unquote, for 176 million Americans? I want to start off by saying that healthcare, I believe, has dual meaning, that it represents both financing and delivery. This, unfortunately, in English, has been a serious problem because the insurance industry has taken advantage of the fact that we do not clearly differentiate between healthcare financing and healthcare delivery. If this was Chinese, we would have separate characters for this, and they would be different meanings. But in English, we can make statements like this: people like their health care, saying it's come from Blue Cross Blue Shield, or people like their health care, meaning like a patient likes the health care they're receiving. To illustrate the confusion behind this, consider this ad from the Partnership for America's Healthcare Future. That's the lobbying group for the medical industrial complex in America. Americans don't want a one size fits all government health insurance system. But rather than showing people behind cubicles in front of a computer screen with their headsets on, denying or claiming, talking about claims, they put this young, cute little girl with her teddy bear in a hospital bed, allowing us to think that somehow or another it's the insurance company that is actually getting the treatment for this young girl. So we've actually had a problem in America because we don't really know what is the health policy of this country. Can you imagine spending as much money as we spend on healthcare and we have no policy by which to guide us? Only in America and only with a medical industrial complex, which is very happy with the fact that most Americans do not understand health policy, that we could get away with the type of robbery, in my mind, that we do with our in premiums and tax dollars. People who do think about health policy often talk about the iron triangle, and that you can consider the iron triangle as quality of care, cost containment, and access to care. It's said in America you can do two out of three, but not all three. For example, we could have great quality of care and very rigorous affordability, but we would deny it to tens of millions of Americans. Or we can have universal health care, great quality, but it's so expensive no one can afford it. Or we can have universal health care, very affordable, but the quality would be so bad no one would want it. But in the real world, we need to have all three. We need quality, affordable health care, and we need it for everyone, not just some people, but everybody. And that is the measure upon which we should measure any healthcare reform package, including the Affordable Care Act. So all this is to say is which direction should we be going to? What have we decided as a nation? Do we think healthcare is a market commodity or do we think it's a public good? And I think it's pretty clear that with the Affordable Care Act, we've decided that healthcare is a market commodity. And the implications for medical practice, I think, are profound. So let's consider each of those three areas: access, cost, and quality. Well, in terms of access, in a market based system, everyone has to buy private insurance and only private insurance. President-elect Biden is talking about maybe having a public option, and we'll see how far he really can get, given the fact that the medical industrial complex is adamantly opposed to it. Now, we could also say the Care Act has a heart, because even though it's a market-based solution, it does provide some subsidies for those who are truly poor, whatever that might mean, so that they can possibly buy their private health insurance. In terms of cost, well, we have to pay for value, whatever value means. Does it mean great quality care, or does it mean maybe you save the insurance company a lot of money? Anyway, all this is added on to the fact that we're asking consumers and patients to pay more so they can become much more price conscious. And we'll talk more about that in a minute. And then finally, in quality, well, most doctors spend all their times in front of a computer typing out stuff on electronic health records. Why is that? Because they use all that data to profile you as a physician and to rate you as a hospital or rate you as a doctor. And so unwittingly, doctors are actually writing their own epitaph, if you will, by putting in all this information into their EMRs. Now, smart people, consultants are going out there and charging a lot of money to tell doctors how to pad their EMR so that they can increase their quality scores under this market-based rubric. Let's talk about each of these areas. How much do you think we spend this year on healthcare? Well, the amount of money is pretty staggering. This year in 2020, that is to say, before the pandemic, we estimated we would spend $4 trillion for the first time, $4 trillion in this economy on healthcare. With the pandemic, it's likely going to be a lot less, but it's still going to be a huge sum of money. And by the end of the decade, we will spend over $6 trillion of healthcare. That is to say, if you add up all the amount of money we spent between 2019 and 2028, we estimate we will spend something like 49 trillion with a T, trillion dollars over 10 years. That is a stunning sum of money, and nobody talks about the fact that we would spend $49 trillion. In fact, the new argument actually is that Medicare for all is unaffordable because, according to the Mercatus Center, which is a very conservative think tank, over the decade, it would cost $32 trillion to actually pay for a Medicare for all plan, such as Bernie Sanders' proposal. That was actually the proposal, that was the solution, the result of Charles Blahouse's research. Ironically, if you figured out from 2018 to 2027 how much money we would spend, it would have been $47 trillion. So 47 trillion minus 32 trillion, the new spin really is that Medicare for all would save this country $15 trillion. But no one talks about the fact that we would save money with a Medicare for all proposal. The United States is a huge cost outlier as compared to other countries. Consider actually this graph. Well, let's put it this way. If you showed this to a kindergartner and said, which of these things doesn't belong here, it would be pretty clear that there's one country, one place, which is way out of line from all the other countries. And that's us, the United States. We spend far more per capita on healthcare than any other country in the world. And where does all that money go? Well, it goes to a lot of areas, but you can pretty much see that almost 65, I'm sorry, almost 45% of it goes to hospitals and physicians. So if you were to cut healthcare costs, what are you going to go after? Well, you go after hospitals and you go after doctors. And hospitals having a much more powerful lobbying group than doctors, it is likely that doctors are the ones who are going to get screwed in any type of healthcare cost containment package. The amount of money we spend on healthcare compared to any other country is astronomical. We spend almost 40% more than the second most expensive country in the world on healthcare. This in a global economy is unaffordable and uncompetitive for us and American businesses. And it's also driving our national debt. If you look at where our money is being spent, it's not, our debt is not actually coming from Social Security or other mandatory spending. It's coming from healthcare. Our healthcare system is simply dysfunctional and it's chewing away increasingly more and more of our gross domestic product that is being consumed by healthcare. This graph is already out of date because we're already close to 17.7% of our healthcare budget. Our GDP is consumed by healthcare. And it's unnecessary. Consider how much we spend on administration. Compared to the United States, we spend 2 to 3 times higher in every area, on hospitals, nursing homes, home care, physicians' offices, on health care, on administration, compared to our counterparts in Canada. And for physician practices versus Canadians, we spend nearly 4 times as much on money interacting with our payers compared to our Canadian counterparts. That is a huge sum of money. In this survey done in 2011, it was about $83,000 per year that doctors waste on interacting with third-party payers rather than getting paid. And this is clearly the win-win. If we could cut administrative costs, we can save the taxpayers a lot of money, and doctors still can get paid very well. Another source of huge amounts of money in overhead is our drug prices. Can you imagine that Martin Shkreli buys a drug called Daraprim, takes it from $13.50 a tablet to $750 a tablet overnight? Well, this actually was such a huge scandal that it made the front page of almost every business article in the country. But the cost of cancer drugs, the cost of Sovaldi for hepatitis C is unbelievable. And so people increasingly have sticker shock looking at the price of our chemotherapy and our medications. And the point here is that you don't, it's not really optional if you are suffering from these illnesses. You really are going to either pay up and pony up the money, or you can potentially die. Now, you would think that this is an incredible scheme to make money, and it is an incredible scheme to make money. The Affordable Care Act, when it was passed, actually was probably the most heavily lobbied bill in the history of the United States. For this one bill, the ACA, we spent $1.2 billion in corporate lobbying for this bill. But if you think about the fact that you're talking about a plan that will affect healthcare for the next decade, and that plan could cost us, what, $49 trillion, a $1 billion lobbying effort is a piece of cake. It's chump change. It's the best bargain you could ever get, which goes to show you that the amount of money that we spend on lobbying on healthcare is so astronomical that it defies rationale and reason in this country. Increasingly, we're talking about value and pay for performance. And what do we mean by value-based purchasing? All of these things are great questions for us. And they have implications for the future of medical practice. So in the old days, it was the patient who would actually pay the doctor directly, or if you didn't have a whole lot of money, maybe you give them, some produce from your farm, or you give them a cow or something, and the doctor would accept that as payment. But increasingly, physicians, uh, realized that this wasn't going to work out. So patients got together and they created something called insurance companies. Back in 1929, they created Blue Cross Blue Shield for a group of Texas school teachers. And that money meant that the money from the patient, instead of going to the doctor, went to the insurance companies, and the insurance companies then would take their share and then pay the doctor directly. But increasingly, the insurance companies said, we want to make sure that we are, you know, paying for value. So they increasingly started putting, uh, onerous tasks on doctors and saying, justify your payments. So increasingly, we find that patients were giving money to their insurance companies, and insurance companies were using more and more administrators to actually uh, prove value for the money that's being paid. And then we decided that actually patients should have some more skin in the games. And so instead of paying doctors directly, which they could, uh, they could we would ask them to pay for high deductible health plans and co-pays. And that way, patients would actually realize that healthcare is not free seeing your doctor. Now, if you have to put $20 to see your doctor, you're going to think twice maybe about whether you have to uh, see this doctor. And that's an attempt to try to rein down the utilization of healthcare services. But the problem is that some services are actually much more cost effective in seeing doctors. And so preventive services and screening, actually, it's worth money trying to see the doctor rather than, uh, uh, get the consequences later on of an expensive medical condition. Uh, but you're not most patients don't really understand that. And so they don't really value preventive care or screening by their doctor. So now the physician has to negotiate not only with the insurance companies, but they have to start negotiating with their patient about the medical care that they have to get. So with this consumer directed healthcare, there's more skin in the game. And the question is, will patients shop based on price and quality? And will they force you to post your fee schedules and your qualities of care, just like, Yelp or Amazon reviews? We'll put those quality reviews online. Do you remember this guy? Well, President Trump, at least for the few months remaining, said it earlier in the State of the Union address. The American patient should never be blindsided by medical bills. That is why I signed an executive order requiring price transparency. Many experts believe that transparency, which will go into full effect at the beginning of next year, will be even bigger than healthcare reform. It will save families massive amounts of money for substantially better care. Well, last I checked, nobody really has seen a whole lot of price transparency, and people are not saving massive amounts of money. But we are actually going to start comparing doctors and hospitals with each other. So, for example, you can go to Medicare.gov, physician compare, and you can look up your doctor, and you can see, how they compare with other doctors. Now, right now, it's very benign because it just says something about where your office is located. But you can imagine that sometime in the future, they're going to start rating these doctors, and you're going to start putting, Yelp reviews and numerical values to what you think about your doctor. And we already know that people put uh, great weight in trying to find one of the top doctors. And this magazine article, for example, is one of the most popular articles that Philadelphia Magazine puts out because it rates the doctors in our area. Even how we use our terms between uh, in healthcare reflects the public good versus the market commodity. So, do we call our patients patients or do we call them consumers? Do we call it a health insurance exchange or do we call it the marketplace? Do we think about it as patient care or do we call it a medical loss ratio? Do we call people with insurance or do we consider them covered lives? So, increasingly, this complex relationship means that not only do we have these under the Affordable Care Act, we created a new entity here called a health exchange. So the patient actually now can go through this health exchange and they can then shop around and then they can pick an insurance company from that. And then that insurance company, of course, asks for provider accountability and paying for value. And then the patient still has high copays and deductibles, so they still have to negotiate with doctors. So the doctors now have a new entity in the mix, and of course, the health exchange is going to take some of the money from paying the doctors. And it's not just the government that's getting into the health insurance exchange business. It's private insurance health exchanges. So IBM and Aramark and other companies are now actually going to these private health exchanges, which then help you shop for doctors. And of course, they take their share of the pie before you eventually pay your doctors. And then to complicate it even more is the Medicare Access and Chip Reauthorization Act of 2015, otherwise known as MACRA. And this was created to end the sustainable growth rate mess, which some people may or may not remember, but actually that was uh, a plan that would have cut physician under Medicare something like 30%. So to avoid that, Congress embraced a new market-based approach called MACRA. And under MACRA, it changes how Medicare will pay doctors based on value over volume, and it combines four quality programs into one merit-based incentive payment system, otherwise known as MIPS. Or it can pay bonuses if you participate as a doctor in eligible alternative payment models, otherwise known as APMs, such as accountable care organizations or patient-centered medical homes, or you agree on their bundle payment models. Uh, these are all new ideas that basically we never teach in medical school. But starting in 2019, physicians had to choose one of two pathways. Either they go on the merit incentive based payment system, MIPS, or they go under the alternative payment model, APMs. And of course, if you're part of a large health system like a hospital system, you are likely to have picked the APM model. But if you're a private practice, you are almost for sure going to be under MIPS. And under MIPS, for example, you will get a single MIPS composite score based on four weighted performance categories. Those are quality, resource use, clinical practice improvement, and whether you meaningfully use your certified electronic health record. And that can give you a MIPS score, and that MIPS score is going to be how they decide whether you're going to get money or not. And it's not actually benign anymore because uh, you can participate in MIPS or you can not choose not to participate. And if you choose not to, your Medicare payment can actually be adjusted so that either you get a bonus and it goes up 4, 5, up to 9%, or it can go down 4, 5, or 9%. So essentially, under MIPS, you will be either rewarded or you will be penalized if you do not actually participate in the MIPS program. So essentially, you actually have a gun next to your head and you have almost no choice if you want to get paid to be part of MIPS. And of course, under the alternative payment method, APMs, you are then required as a health system to have certified EHR technology. You have to agree as a health system to be at risk for the losses that you have, or you agree to be part of a patient-centered medical home. Anyway, it's very complicated, all this, and most doctors, if you ask them, what do you know about MIPS or APMs or MACRA, they have no idea what you're talking about. And for good reason, because, for example, this is on the CMS website. Most advanced APMs are also MIPS APMs. MIPS eligible clinicians participating in advanced APMs are included in MIPS if they do not meet the threshold for payments or patients sufficient to become a qualifying APM participant. The MIPS eligible clinician will be scored under MIPS according to the APM scoring standard. Well, that to me is not even English. Can you imagine diagramming that sentence? I mean, how can anybody understand what this language is all about? It is unfathomable. But this is what happens when you have a market-based approach to paying doctors. Well, the people who are happy about this, of course, are the people who get to manage the system, the administrators. So in this famous diagram, the number of physicians has grown in yellow, but the real growth rate in healthcare is in blue or green, depending on your monitor. And what that means is that we have huge numbers of administrators who oversee how medical practice is being done, and they're making a lots of money uh, being extracted out of the system because of this. We could have made this very simple by using, a single payer model. But instead, we've chosen this very complex, convoluted market-based approach using this Affordable Care Act. And, to the consternation of most Americans, they do not understand the Affordable Care Act, and they've gotten used to all these crazy arrows that we have in how healthcare works in this country, which is unique in the world. We could have actually taken all our money, put it into a national health fund, and then pay doctors and hospitals uh, or long-term care directly to pay for medical care. This concept would have cut out the middleman and saved this country billions, hundreds of billions of dollars. Now, here's interesting enough, the public is actually ahead of the game on this issue. More and more of the public increasingly supports the idea of a national Medicare for all plan as compared to the Affordable Care Act or any other plan that has been proposed. And it's likely, given the pandemic, and as more people have lost their employment-based health insurance, more and more people are going to favor a Medicare for all plan. It's simpler. It makes much more sense. It saves administrative costs.
Employee, they tell you what to do. Nothing could be further from the truth.
Just take a listen and see how blood pressure's doing today.
I'm in practice. I'm a small business person. They're not running my business for me. They don't come in and review me and tell me, you're not doing this right, you're not doing that right. They're the ones that pay me for the work that I do.
This is what I do to bill for one patient. I bring up the patient, click on you, type in the codes, a billing item and a diagnosis code. The date is already filled in for me. I create bill and it's done.
It is very simple.
Yeah, it's very simple. In Canada, they can bill in 13 seconds in your doctor's office. Compare that to what we do in America. It's crazy. In fact, if you look at America versus Canada's administrative costs, we're talking about a savings of something like $628 billion in a study that was done in the Annals. That's a huge sum of money that we could use right now to help out our economy, which is in shambles. So why does single payers save money? Because there's competitive purchasing of services. That's actually how the free market should work. I'm the purchaser. I say, you give me the best price for, this this drug or this medical procedure or whatever, and you'll get it, and you will get people who really will compete based on that. You can negotiate fee schedules and prices. You can reduce administrative costs. And the real strength, I also think about this, is that we could have a robust information management system. Consider, for example, Taiwan.
Its new health system using state-of-the-art information technology. Everybody here has to have a smart card like this to go to the doctor. The doc puts it in a reader, and the patient's history, medications, etc., all show up on the screen. And then the bill goes directly to the government insurance office and is paid automatically. So Taiwan has the lowest administrative costs in the world, less than 2%. Compare that to the endless paperwork and all the denied claims we get with for-profit U.S. health insurance.
Yeah, think about all the money that we spend. Now, look at this. How hard is it to do an electronic medical record in Taiwan? You have a card reader, you have a TV monitor, and that's it. You hook it up to the mainframe computer, a national health database, and actually Taiwan is able to uh, do this program. Ironically, this smart cards system was invented in America, but we don't use it in this country. We sell it as an export product to Taiwan. Uh, that's ridiculous that we would do this system the way we do. Taiwan, incidentally, because they have this national database, they actually can track their pandemic. They know everybody who has been tested for COVID. They know who's positive, who's not. They even can integrate their travel history because they know all the people who came in from the airport or by sea into their country, and they can integrate that into their electronic medical record. So Taiwan actually has one of the lowest case rates of COVID in the entire world. And they're only 100 miles off the coast of China. Think about how remarkable it is that their national health database has actually helped save thousands of lives in Taiwan. So think about this, that single payer actually is a very mainstream idea. People think it's a left-wing socialist idea that we talk about the poor and disenfranchised, that we're critical of American businesses. It's a radical idea. Is what's radical is our current system. Our current system is radical. In fact, single payer makes so much sense. It's a centrist mainstream idea. It's about creating more jobs and improving uh, healthcare for our families. It is very sympathetic to American businesses because the current system is very onerous on most businesses. It's very expensive. It's patriotic to support single payer, and it stems from the idea that single payer is healthcare as a public good. Not only do we think it's a good idea, but the American College of Physicians, the second largest physician group, supports a single payer plan in their most recent uh, article in the Annals of Internal Medicine. Which brings us to the end to talk about healthcare as a public good or a market commodity. Here's the distinguished Sir William Osler, who said, "The practice of medicine is an art, not a trade, a calling, not a business, a calling in which your heart will be exercised equally with your head." And I believe actually, when we think about healthcare as a public good, we will be better off as a country. If you have any questions, please go to the PNHP website or you can email me. Thanks so much for your time and attention.